pronounced phonetically, so I'll try not to use that term. But at any rate, today what we're going to begin with are the projections that demonstrate the intercondylar fossa. That's this guy. That's the fossa that we're interested in. Okay, there's a series of ligaments in there, the anterior and posterior cruciates, and they are the ones that have a tendency to be injured with sports. This way, and usually it's this kind of injury or a twisting injury. Also where we have a lot of wear and tear over our lifetime. Okay, just like our tires wear out, our joints wear out. I always think that's a pretty cool anatomy. I mean, an analogy. The difference is you can replace your tires, but it's a little more difficult to replace the joints. So we take care of them by keeping the muscles strong, the large muscles strong, on the femur and as well as the tibia. Okay, but they're still going to wear out. Okay, the good news is they have great replacement components. They've even figured out that men and women's knees are not the same, so they now have female components that are designed for the way we walk and our body. Okay, with that being said, these next ones are to demonstrate this region in here. And if you can remember that's the anatomy that you're interested in, you'll notice that all of them, even though the patient is in a different position, the anatomy is not. And you find that the leg, which is attached to the entire body, so keep that in mind, the leg is going to be flexed between 30 and sometimes as much as 60 degrees depending on the exact position. The central ray is going to be perpendicular to the tibia and fibula. When it's perpendicular to the tibia and fibula, it will be parallel to the, what's the space? This
Tibial
area?
plateau.
The tibial plateau. Okay, so that's what you want to remember. Okay, so let's look at the Camp Coventry. With the Camp Coventry, the patient is, as you can see, is prone, and then the lower leg is flexed 40 to 50 degrees. Range, because it depends on what you can get, really, and what your equipment can handle. Our central ray is going to be perpendicular to the lower leg, and it's going to center at the popliteal crease or the popliteal fossa. That's this place at the back of your knee. Okay, it's an indentation back there. Because the beam is angled, it's going to exit at a point higher than where you enter, and it's usually somewhere about a half an inch below the apex of the patella, somewhere. Okay, here's what we're looking at. Here's the intercondylar fossa. You want to use the entire name, not just the fossa, because there's various fossas all over the body. Here are your intercondylar eminences. This is where the ligaments, one is an anterior and it is posterior, and goes in between that space there, and the other one comes posterior and attaches anterior. Right now, you don't need to know which one does which. You also are able to see the joint space here. These are called the articular facet. Facet is refers to a joint that articulates with another, with a structure near it. So in this case, it's going to articulate with the patella here, the medial and lateral condyles, right in here. Okay, that's that smooth surface. So if you look at the knee, if you look at this guy, here's our articulation, and we're talking about this smooth, kind of rounded surface here. Okay? That's the wear and tear. This is probably the most complex joint in the body, next to the hip and shoulder. Okay, so the patella should be in the midline. So when I was talking about how the leg is attached to the entire body, that means you want to look at the coronal plane, the sagittal plane, all the way down the entire body, including the leg. So the leg can't be over here and the body's twisted this way. Okay, we don't want to do that. We want to keep it in alignment, and that's going to help us have the patella in the center of the distal femur. Yes?
Doesn't the way a person walks makes a joint wear out faster? Yeah, does it depend on how the person walks?
Not necessarily, and now you're getting into orthopedic stuff that is beyond the scope of this course.
Oh, okay.
Okay, so we have the intercondylar fossa in profile. There's no rotation as demonstrated by the patella. The articular facets and intercondylar eminences are well visualized. Optimal exposure factors, and for those of you who've had me either for image analysis or for lab, when we talk about optimum exposure factors and it's going to say good bone detail, what are we talking about? What's good bone detail?
Like there's either trabecular.
Okay, we see the trabeculae, which is at the distal and proximal ends. What else? Somebody else?
Bone marrow.
Bone marrow, so we know that this is going to look, differently. And what's the third one?
Compact bone.
And the compact bone, which is going to appear white because
It's more dense.
because it's denser. Good. See, you're already ready for the technique formulation class next semester. Okay, so the patient is going to be prone on the table and the knee flexed to perpendicular. And I'm going to go forward and then backwards. Where's his? Did he show you the other ones for the condyles? The one with it on the stool?
Yeah.
Yeah. If you do that one, make sure you have the patient hold on to the table, so get them close to the table, so they have something to hold on to, and put sandbags around the step stool, or around the stool. And did he show? Let's see. There's this one. Did he show you the AP?
AP knee.
For the condyle? No. Okay. But he did show you the one with the patient on their hands and knees.
Yes.
Okay. Concept is still the same. However you do it, concept is the same. Flexion of the knee, central ray, parallel to the intercondylar, to the tibial plateau, perpendicular to the lower leg. Okay. Moving on to patella. Okay, so for the patella, we want to isolate, we want to have the patella perpendicular to the image receptor. And so the beam is going to pass through just underneath the patella so that we can see the space in between. And I'm going to go back to the other one so we can see the space in here. So that is the patella femoral articulation. So you can see this guy's perpendicular to the image receptor. We should not, this is a little bit of the tibia right there. This is the femur. And we don't want to see any more than this. So when we overflex the knee, we do. All right, so how do we position? Okay, so for the patella and the patellofemoral joint, the patient is going to be sitting. You're going to have them flex their legs approximately 45 degrees. And sometimes it'll be done bilaterally, but more often this one is done unilaterally. The image receptor is going to be placed on the knee, and you want to keep that image receptor so it's perpendicular to the beam. And I'll show you that on the next slide. The central ray is going to come just underneath or be perpendicular to the joint space between the patella and the femoral condyles. Close collimation. This is generally one where they'll let you collimate. Yay! Because I know most of the time you collimate, they stay open. You collimate, they stay open. Okay, the criteria is the patella profile, the joint space open, and bony detail, and we know what that is. This is the Settegas method. You don't have these slides?
Yeah.
No, this one's
It is?
Yeah, you have these slides. I know I saw them somewhere.
We just don't have that particular one.
Not the last one.
This one,
Yeah.
write it
That one,
down.
criteria?
I will tell you again, The reason we had so many fail in the last class is because they were busy taking pictures rather than writing. The brain learns by writing. Okay, and this is in your textbook. So if you were reading your notes, you're reading the textbook before you got started, you would already have this written down. Because you have the slides. So I'm gonna put the evaluation criteria for the slides. Okay, on my notes. That's why he doesn't give you everything. Okay, you thought I was gonna be the same as Raphael? All right, so the distance here should be 40, even though this doesn't show 40. The reason it doesn't show 40 is they wouldn't be able to get this picture. The tube was 40, it would be here somewhere. We wouldn't see it. So, we want to adjust the image receptor, and if you're gonna use an 8x10, small part, small image receptor. If you're using if you have digital and you're using the free cassette or umbilical, you want to try and get that huge 17x17 so that the patella is in the center of that device. Try and make your image receptor as parallel to the tube as you can. A little challenging. If you use a sponge between the knee and the patella, be sure it's a clean sponge. Meaning that it doesn't have anything that will cause an artifact. Patient can hold it even if they're lying down. Maybe you'll use another sponge to help them hold it. Okay, it's an opportunity to be creative. Okay, and there's our image. Okay, any questions about a set of yes?
So if it does get closer to the patella, you said that was the fibula? Or
Yeah, this
if
is
it does get-
this is the fibula. The fibula is down there. This is the tibia, the femur.
Yeah,
Okay, and that's peeping right there. That little peep is the tibia.
so if you get superimposition there,
That's-
is it a redo?
It should be. It should be a redo because we're not showing the space, and it's because there's too much flexion. The more you see here, the more flexion that you have on the leg, which is not appropriate. Now, if that's the only way you can do it, the patient's not able to, do less flexion, which for the life of me, I can't figure out why. But in the event, then you would make a note on the requisition for the radiologist or wherever they put it, so that the radiologist knows you attempted to do it correctly, but you weren't able to, and you recognize it isn't, perfect. This, there's great pictures in your imaging analysis textbook that will show you errors. Remember, the image analysis textbook focuses mostly on errors. Okay, the merchant method, the patellofemoral joint. I've added some slides that you don't have, and you don't need them, because I want you mainly to listen to it. Okay, the merchant method is a little more complicated because we use the merchant device. The more you use it, the less complicated it becomes. Okay, the positioning. I'm gonna come back to these. I want to show you what it looks like. Okay, there's the merchant board. There's the patient in the merchant board. They're adjusted so that the knees are flexed, the lower limb is flexed about 40 degrees. There's a sponge underneath here to make sure that the knee joint and the hip joint are in the same plane. It's really the key of doing these well. Okay. Okay, so here's what they look like. If I said I'm gonna go back to the other ones, I have one in here. Okay, and there's your central ray. So you'll notice that the knee joint and the hip are in the same plane. This device was elevated, a little padding underneath there because it's not terribly comfortable. Our central ray is from 48 to 72. You'll probably find that most techs use 72. I use 72. It's always done bilateral. And why do we do bilateral exams? For comparison. Great. And since it's bilateral, you'll mark both of them.
Okay.
Okay. And that's what it should look like. That's your shadow. Okay? All right, so I'm gonna go back, don't get dizzy. So if you do, you just fall on the floor, and we'll just step around you. How do we position the patient?
Do we pronate the marker?
No. No, the marker, you're gonna have them looking at you. Yeah. Okay, positioning. Place the patient in supine with both knees at the end of the radiographic table. You're gonna support the legs, the knees, and the lower leg by the cassette holding device, that's the merchant board. So here's your merchant board. This needs to be a little higher. That's probably 40. Now, most of your devices at the hospital, they have a marking on them, so you'll know where to place it. Okay, good angle for everybody. Okay, now, I would adjust the device to 40 degrees before putting the patient's legs in there. The knees and the feet need to be close together, and you're gonna use some kind of strap. They usually come with something like this. You're finding a lot of them are a lot larger because when we have patients that have, a lot of adipose around their thighs, they can't get their legs close together, but you really wanna squish them. Okay, the fat's gonna displace, so you can get them a lot closer than when the patient is just lying, just has them relaxed. Ask them, tell them, I need you to get your legs as close together as you can, and then I'm gonna put a strap around them to hold them in place, okay? Now, if the strap doesn't fit, because they're too big, you can always use a sheet, be creative. And usually there's some Velcro straps around, so that you can use those. Okay, you want the patellas so that they're aimed towards the sky, and that's going to make sure you have a true AP distal femur. You're going to place the cassette against the legs, usually around the ankles. If you're using the umbilicals or free cassettes, they are heavy, so you'll see a lot of techs will put a towel on the patient's ankles to keep them from being so uncomfortable. Okay, central ray should be perpendicular to the IR. It's about a 30-degree caudal angle from the horizontal plane. Okay, so what does that mean? My arm is in the horizontal plane. My body is the tube. Okay, didn't know I admitted radiation, did you? Okay, my body's a tube, and so I'm going to angle caudad 30 degrees. Okay? Distance, 48 to 72 inches. Collimation should be tight, collimate on all sides. The criteria, patellar profile. Open patellofemoral articulation. The condyles and epicondyle sulcus. So, we're looking here. Okay, beam is through here. So we're seeing this region, the space in between. Okay, and the patella should be in the center of the femur, the distal femur. Okay, there's the merchant device. Merchant device with the patient's legs in it. And there's our image. And again, with this one, we should not see any of the tibia. The biggest problem with these is they're overflexed. If they're positioned properly, it'll be open and beautiful just like that. Now, if it's not that open and it's positioned well and you don't see the tibia, why might that be?
Arthritis. Arthritis.
Could be because they have pathology. We're not gonna try and name the pathology. Okay, so this is what we can see. This is all from Martinson. The joint spaces are open without any superposition of the soft tissue of the thigh, unless they're really big patients. Then you're gonna have all sorts of goodies in the way. Okay, so let me go back to talk to you about the body. It's not the words I want you to see so much. I think this is what's most important. Now, this angle here is too great. So there's too much flexion here on this one. It's really hard to find a perfect picture. Okay, so the 72 inches reduces magnification. Again, this is all from Martinson. And what she's saying is that in some places you'll find the tech will have it perpendicular and then they'll angle slightly cephalad, or they might angle a little bit more caudad than being exactly perpendicular, and that comes from Martinson. Don't worry about that 5 degrees. Okay, I know I have some really good ones, shows you that. Okay, so why is it important to do the merchant? It's because the quadriceps femoris are now relaxed. These guys up here. And we particularly want to relax this one, whose name I can never remember, because it changes the position of the patella. Remember, this patella is really amazing. Well, like the rest of the body, because it moves back and forth. I mean, it's not fixed here. You know, it's attached to a muscle in the femur. And so when we extend and flex, okay, this guy is moving back and forth here. Okay, if you put your finger on your patella and move your leg back and forward, you can feel how it moves with the joint. Okay, and some of you may feel a little bit of cricking, little kind of cracking, kind of.
Yeah.
I see smiles, so some of you are doing, okay, wear and tear. Okay. All right, so we go back here. So as you can see, the foot is in alignment with the patella. Okay. All right, so with the merchant, you could, sometimes you'll have to raise the merchant device so it's higher than the table, so that this is parallel. These joints are parallel. And other times you will have to put a sponge, you know, underneath there, keeping it at the same height as a table, and making sure you have this one here. And yes, you can take a picture of this one because I made it, so you're not going to find it anywhere.
Bless you.
Thank you.
You got it? Ethel?
Yeah.
Not Ethel yet, yeah, okay.
Sorry.
Okay, so here is one that's not quite positioned properly. Here you see all that shadow. Positioned properly, and I think that was it. Okay, so any questions about the projections for the knee? Yes?
One of the last slides said, the one you said, this is why it's important to do the merchants. It said to prevent false negative. What does that mean?
Okay, well, if we don't position properly, okay, so even, now, there's some doctors that will accept it, but, you know, there's all sorts of creative ways we've come up to because techs hate using the merchant. device, they think it takes too long, so they'll have the patient flex and sitting on the edge of the table. If that foot is behind the image receptor, there's no stress on the knee, then it will display properly. If the patient has any stress on these muscles, the quadriceps, then it may give you a false negative because the patella is not going to be in its natural position. It's in its working position. Okay? Any other, yes?
When someone refers to the sunrise, are they referring to the setagast or the
The
merchant?
setagast. The setagast is properly the sunrise. The other names for the merchant has been the mountain view. And I think for many of you, I told you that actually came from the fact that Dr. Merchant had an office in Mountain View. Okay? So that's where that name came from. I don't think this looks like a Mountain View. Another name I've heard for this, the setagast has been sunset. Okay, I think that whenever it was physicians asking for that, it wasn't radiologists. I personally think they were being cute, but whatever, the term is out there. When somebody tells you, from a doctor tells you, especially an orthopod, but if they tell you to do a sunrise, ask them, is that a setagast or do you want it with the merchant board? And I always refer to the merchant board in case they don't remember that name, the first part of it. Okay, there was another hand. I thought. Okay, don't try and think up questions if you don't have one.
I forgot my question.
Okay,
I just
femur,
forgot.
like any other long bone, ask me when you remember.
Okay.
Okay, so as like any other long bone, the femur, we have to include both joints. So for most of us, with few exceptions, most adults, we're going to have to take two images. One that includes the distal and as much of the shaft, and then of the hip, or we could do from the hip joint down and then the knee. Okay, the way you do that, the series would depend upon where the injury is. So you want to do what is appropriate protocol for your facility. So you may find that if it is the hip area where the injury is closer to the hip, then they would want from the hip joint down and it's separate of the knee. Okay, because usually we're looking at fractures of the shaft here. Okay, and depending on the injury, the shaft could just break, so that we have a nice clean break, or if it was twisted, then we'd have one of those spiral breaks so that it could be the link here. Okay, so how you do it depends upon what they're looking for, what the clinical history is. Oh, all these little buttons on this thing. Okay, so we're going to do AP and lateral. We knew that, right? Because that's one of our basic rules. We're going to at minimum do 14 by 17. Now, are these done Bucky or tabletop?
Tabletop.
Bucky.
Okay. Why did we say tabletop?
Because I looked in the slides and they said, and then I saw pictures of them doing it.
Okay, so from what you read and you saw.
Yeah.
Okay. Why did you say Bucky, Jackie? I know you said Bucky.
I say Bucky.
Okay, we have a Bucky over here. Ann, why Bucky? Oh, you didn't say anything?
I said because I think it's big. That's why the size.
Because of the size. Okay, now when we use, and that's correct, when we use the term big, that could be just all over big. For us, we're going to use the term that it is a thick part and it's going to be dense. Okay, because for us, big doesn't really describe it. Big is, I think of big as being, somebody that's tall and really broad, or they could be short and broad. Yeah. Okay. All right, so we're gonna use two 14 by 17s. The 7 by 17s, nobody has those anymore, and we got the last of them here, and even that one has disappeared. Okay, the minimum is 40 inches. You'll find that some of your units are doing 44 because if we use greater distance, then we can get more anatomy on. Same concept as tib fib. Pathology, fractures is usually what we're looking at. Bone lesions, dislocations. Dislocations, you're going to find that those, of course, would be at the pelvic region, so we'd be doing a pelvis and so forth. The most common way of having dislocations is motorcycle. Yeah, motorcycle accidents. Wow, those motorcycle accidents can just really tear up the pelvis. But they're really good at putting it back together again. I mean, we're, sometimes we are kind of like Humpty Dumpty. Okay, so AP, positioning. Patient is supine. We're going to align the femur with the IR. We're going to do the whole body. Okay, not just have the femur in alignment, regardless of where the body is. Now, we want to have a true AP. In order to have an AP femur, I'm going to go back there in a minute. If you look at this guy, this is this joint is not perpendicular to the bone. Okay, it's at a slight angle. So we rotate the leg internally to make it the whole leg, not just the foot, in order to make this region AP. When you do that, your knee will probably no longer be AP. Okay, just keep that in mind, because if I'm interested in the knee, that's where my injury is closer to than I would do one with a true AP here. Okay, but otherwise, for the standard, for our practical, we'll rotate, the leg in. If we're doing distal femur, it's only about 5 degrees, but if we're getting the proximal end, we're going to rotate the entire leg in 10 to 15 degrees. Okay, so if we're doing distal end, I don't know why they write it that way. I really have to write a book. Okay, I don't know why they say it that way. Because what they're actually saying is that they want you to have the distal end so that the joint is a true AP, which means the epicondyles are parallel to the image receptor, equidistant, and that's probably about a 5 degree internal rotation for most people. Okay, so that's for distal end. But if you're doing proximal, you're going to rotate the entire leg, and don't rotate the hip. You're going to just rotate the leg in 10 to 15 degrees. Now, have I thoroughly confused you? Annie said, yes. Well, okay. Okay. Think anatomy. If I'm doing this end, proximal end, I want this end AP, true AP, so I have to rotate the entire leg in 10 to 15 degrees. Okay, got that?
Got it.
All right.
Got it.
So if I'm doing the distal end, I only need to rotate the entire leg in about 5 degrees in order to get the epicondyles. If you drew a line from epicondyle to epicondyle, that line would be parallel. Okay, yes.
If, for example, you're trying to get the distal femur and then you're trying to use the epicondyles to see if it's in a true parallel, but you could not do that if the patient's knee is injured, what would you do in order to use?
Look at it.
Okay, so just.
Yeah, I'm in a visual and I'm gonna, think I'm an X-ray beam. I can position the other leg, okay? And I can, see, how that's looking. Now, if you're doing a severe trauma, you're gonna get 2 pictures at 90 degrees, whatever they are, because if there's, severe trauma and there's probably a fracture, and you're gonna know the difference. Have any of you done any patients that had fractured hands, wrists, ankles yet? Yeah.
Seen.
Yeah. Okay, or you've seen it. Okay, so when you've seen it, haven't those patients been different than the one that comes in? Yeah, that's why we pay attention to our patient from the moment we go to the waiting room or wherever, the hallway, wherever we get them from. Okay, because it's visually, we're gonna be able to see whether there's stuff going on. Yes?
To get the 10 to 15 degree, do I see text asking people to point their toes in?
I know, I
But you
wish
want the
they wouldn't
whole
do
leg
that.
to rotate,
You want the
not just
whole
the foot.
leg. Okay, now remember, your feet can do this. So when you tell people to rotate, what are they gonna do? They could just turn their feet like this. Okay, without moving the leg. Okay, I can do this without moving the leg. I want that joint. So I'm gonna tell them, to rotate your leg. Okay, now, they end up being pigeon-toed, if you do it correctly,
Yeah, right.
but the foot should be, and I dorsiflex them just until I get them this way. The foot should be in alignment with the entire lower leg. Okay, and I can tell you that the techs are doing it wrong, and then when you go back and tell them, Pam said that you're doing it wrong, they laugh.
That hasn't been my experience.
Oh, it hadn't been your experience? But you have to say Pam said it or Raphael said it. And then at least they roll their eyes.
Yeah, that's closer to it.
Darn, then that campus are always telling you these things, okay? But, at any rate, we're gonna give you the most correct way to do it, the standard way of doing it, and, at the end of the day, look at the work that they're doing. Because you're working with some techs that what they do, they have to do repeats. Oops. Okay, and they get nasty notices from the radiologists. So, anyway, there's a right way, there's a wrong way, there's Merrill, there's bone tragger. All right, so, all right, most of the time, you're not going to get the entire femur on one image receptor. Just because of the length of the femur. Height is not necessarily a good way to determine it because, as you've noticed even in the class, that some of your classmates have short torsos and long legs. Okay, those are the kind of people that make good runners. Okay, nice long legs. They can do hurdles. Okay, then you see other people that have long torsos and short legs. They make great rowers. They have that. I'm serious.
No, I see what
Okay.
you mean.
All right, so, you are gonna try and get the area of interest on one 14 by 17. Most cases, a second smaller is taken to show the other joint. Place the bottom, and we're talking about bottom up. We're gonna put the image receptor 2 inches below the knee joint, or what am I gonna use for, a landmark for the knee joint?
Marker.
The tibia.
The condyles?
The condyles, okay, so I'm gonna need to be 2 inches below the condyles. Why so low? Begins with a D. Divergent ray, who said that? Yay, okay, divergent ray, okay. So you're gonna have it about 2 inches below the knee joint for the distal femur. Now, if you're doing proximal femur, proximal, if you're doing proximal femur at the level of the ASIS. Okay? The central ray is going to be perpendicular to the femur. I direct the central ray to the midpoint of the IR because this is a case where we adjusted the IR to the patient. Now, so many things we have taught you, center the central ray and then adjust your image receptor to the central ray, right? And a lot of that. Okay, but this is not what we want to do here. It's the opposite. We adjust the image receptor, then the central ray is centered to the image receptor. Collimation on both sides, lead the length, because you need it. See, the majority of the femur and the joint nearest to the pathological condition or injury should be demonstrated. Okay, now, if they have orthopedic devices, okay, like the tibial rotting, any of you been to surgery and seen a tibial rotting? One person, okay, and that's probably right, most of you won't see them until next year. Okay, and it took forever, didn't it? Yeah, they take forever, because what they do is they put a rod down the shaft of the femur. Okay, and you've got to get that perfect. Okay, and any orthopedic device, you have to see its entire device. No rotation on the knee or distal femur, if you're doing distal. If you're doing distal, you'll see a little bit of the lesser trochanter in profile, and then when you're doing the proximal femur, you'll see a little bit of the lesser trochanter. Look at images there. Okay, distal femur, bottom up. Now, what this one is here, I don't like the way he set these up. Okay, we always talk about each other. Wait till Raphael teaches some of my classes next semester. Okay, so this is an image of the distal femur, and it looks like they're using, okay, this is, I'm not sure it's a 14 by 17, but anyway, the point is, they're getting from just below the apex of the patella up. I would not have my apron this low, because the apron somehow will always get in the image. So yeah, but if you're doing distal on male or female, you can shield. And you want to shield whenever possible. Okay, and there's our image. Here, there's the apex of the patella, right there. And you can see we have that entire joint on there. Sometimes what happens is that we have injury in that joint. So we want to see the other, that involves the joint, not in it. So we want to see the tibia and fibula. Okay, proximal femur. We don't see the ASIS because it's up there, right up there somewhere. Here's the acetabulum, and we should be about 1.5 inches above the acetabulum. We can tell that the leg is rotated internally because we see the femoral neck in profile. There's the greater trochanter, and we have the lesser trochanter just peeping at us. A true AP, it'll just peep, kind of just peep out of there. Yes?
So that on the neck area, that little white spot, that's calcification.
I don't know what it is. Okay, I don't know what that is. Okay, and I'm not gonna worry about it at this point.
Okay.
Okay, so, this is the ridge here, femoral ridge. We also see part of the pelvic brim. What's this guy called?
Obturator foramen.
And this here?
Ramus.
Of
The fusion.
yep, and this is part of the ramus there. Okay, it's the condyle, the ramus. Okay, for the lateral positioning, patient's going to rotate towards the affected side. Please don't tell the patient oblique to the affected side. I still see some of that. If they can, depends on their condition. Flex knee 45, just like we did for knee. Place the unaffected leg behind. Ooh, we're gonna have the patient's gonna be kind of doing a scissors with that one back. You know, with one back. It's kind of I think of it as scissors, okay. The IR should be positioned 2 inches below the knee joint for the distal femur, for the proximal at the level of the ASIS. So that part hasn't changed. Adjust the patient's pelvis so that it is rolled posteriorly 10 to 15 degrees from the lateral. So that means you have the patient roll up towards their affected side, and then you're gonna have them rotate their hips back because you want this part out of the way. So roll them up towards the side and then roll posteriorly from the lateral. The central ray, again, perpendicular to the femur and the image receptor, midpoint to the image receptor. Okay, so collimation, both sides of the femur. Okay, the majority of the femur, the joint nearest interest to the pathological condition, or injury should be demonstrated. Orthopedic device in its entirety. Okay, femoral condyles are not going to be superimposed for the distal femur. Close, but they won't be. The opposite leg should not superimpose the affected side. Patella should be in profile. So, proximal end, greater trochanter is pretty much over the neck, femoral neck. We see the lesser trochanter. Oops, that was the ischial tuberosity, not the Raymond. Okay, that's the ischial tuberosity. I told you it was something else. Okay, and then we see the femoral body or shaft. I'm with you. Monday's a hard day. It was cold and windy all weekend. Bed weather, you know, bed weather. Okay, so here's what the patient looks like. Okay, and it's very difficult to shield the females. You really can't. Males, unless you have a testicle shield, it's pretty hard to shield the testicles. You can see this part of the body looks lateral, but the knee, if you're doing distal in, it's not lateral. Okay, for the distal femur. Now, for distal femur, I have the patient roll onto, to bring their hip and leg anteriorly, just like you did for a knee, right? Isn't this what a knee looked like? You're just centered higher. Okay. Oh, where's the bottom of the image receptor going to be? Because remember, we're going to position the image receptor.
For distal, it'll be like 2 inches.
2 inches below the apex of the patella.
So that's not low enough.
Yeah, it's not low enough. Sure isn't.
No, but
The only way we're ever going to have perfect images is if we do them ourselves in our spare time. So, all right, so let's say we have the patient cannot do, we cannot roll them onto their side, it's trauma. We would do a cross table. And now you're used to doing cross tables, right? And you know that when you're doing a horizontal beam, that your image receptor is going to be perpendicular to the table. We do have to elevate, and that's not so. Oh, you could also do a lateral tib fib like this. Huh? Pretty cool. Oh, you could do a lateral knee. Wow. We do a lateral ankle just like that. See, you see how everything really fits together? And when I'm forever telling you, you know more than you think you know because you have some previous knowledge. Because we didn't show you, did we show you a cross table tib fib? No. Now you've seen one. Did we show you cross table knee? No. But now you've seen one. Okay. This one in particular, the image receptor is this low. You know, you look at it and say, well, it doesn't need to be that low. But you can't get it up any higher. Okay, because it's between the patient's legs. This is a shield. This is, there's your marker. That marker is really in soft tissue, so it should be down here.
Would the bottom of the IR include the whole flesh or just?
No, it won't include the soft tissue here.
No.
But it will get it here.
And that's how
I
it
don't
should
like their
be?
collimation.
Or is that too
It's-
tight?
No, no, they would have to I would open this so that we see all of the soft tissue.
Okay, that's what I was asking.
Yeah, good. Glad you did. Is that clear? Okay. And as you can see with our lens, most often, even when we're doing distal femur, we're not true lateral down here. And the main reason for that would be, it's not a positioning error necessarily, because this meets the criteria of a lateral tib fib. You know, we have the fibula in the just barely superimposed, slightly superimposed. You know, it's about 2/3 superimposed. Why is that? You know the answer to this. Not because it's trauma. This has to do, it has to do with geometrics. No, it's true, it's really close to a true lateral, because we can see the femoral patellar joint space. You know, it's just that our condyles are not superimposed. What might have caused that? Yes,
Probably because one of the condyles is higher than the other one.
not in this, that's a little bit of it, but that's not the main reason.
Okay. Divergent.
This has to do, diverging ray. This has to do with the diverging ray. If you're centered up here, you're not gonna get the joint lateral,
Okay.
okay? Okay, and then,
No, I was laughing at what she was saying. I was listening on to a conversation, I'm
Yeah,
sorry.
I asked them, what's the question?
I guess I'd laugh too if I heard that. Okay, all right. Any questions?
What's the question?
Okay. So let's do a little review. I have to figure out how to get this guy over here, and here. This, that, and that. So is, oh, it's FN. Aha. I want duplicate. Okay, would you like to do a little review?
Yeah, sure.
Let's see here, we're doing. Okay, reminder. This this limb, the lower leg, the entire lower leg, is in the anatomical position. So your joint's gonna be, your knee joint's gonna be AP and the foot's gonna be facing forward.
Okay.
Remember, you want to adjust the entire leg, whether you're doing a foot, a toe, an ankle, a leg, doesn't matter. Okay, I'm gonna go through these guys. You have to study your anatomy on your own, but I will show that one. Oh, we'll remind you of this. Okay, so when we're talking about doing AP knees, and we're doing the angling, okay, it has to do with having all three joints in the same plane, and the fact that the tibial plateau generally makes the plane of the tibial plateau is probably about 10 degrees caudad. So when we're trying to open this guy up, like when you're doing the Rosenberg, that's part of the reason for your angle. Okay, remember how much angle do we do on a Rosenberg?
10.
10 degree. Oh, there's 10. Wow, see how those things work together? I never figured this out until I started teaching it, so, you know, that's why I get excited. You all, you just think I'm weird, that's true too, but, okay. Okay, so I know we have a knee. I thought he had a knee, I guess he doesn't have a knee. Okay, well, this'll work. Okay, if you were to draw a line from the distal portion of the lateral and medial condyles, you'll see that it is about a 5 to 7 degree angulation here. So if I was doing a cross table lateral, it would be real simple for me to say, oh, okay, I'm doing a cross table lateral, so I've got to angle caudad about 5 degrees. Now, the techs, when they do a lateral knee, how much do they angle? About 5 degrees, right? Okay, Yes? How
No,
many of
I
you
don't-
seen knees?
Not the cross table one I
Okay,
had seen.
so how many of you seen knees? A knee.
I need.
A knee, doesn't have to be cross table.
Okay, yeah.
Yeah, a knee. Okay, you've all seen a knee. When they do a knee, a lateral, standard lateral knee, they roll them up on their side, and don't they angle most of the time 5 degrees caudad?
Yes.
Yes, okay, that's because of this. So the point I was trying to make is if you think of it as being a cross table, you know, it's really simple if you're looking at it this way, is what I'm saying. Okay, so that's where that angle comes from. Okay, landmarks. Distal, the distal portion of the patella, the apex, always confuse me. You have, it's a 1/2 inch to the joint, so no wonder we have to center 1.5 inches to 2 inches below the apex of the patella when we're doing femur. Okay. Okay, on toes, the texts are usually from 0 to 10 degrees if we're just doing AP toes. Your text says 10 to 15 degrees towards the calcaneus. We're looking at the joint spaces. That's what the angle's for, to open up the joint spaces. And remember I talked about how if the toes, you know, from wearing, I really have this thing about feet and shoes. I really do. So if you've been wearing bad shoes and the toes are like kind of curled up like that, okay, then you're gonna have to angle because you can't get them flat, right? So you would angle to 15 degrees. Most people 10 is gonna be sufficient. That's for all toes. If you're doing individual toes, see these guys aren't quite open. See those toes curl down? Those joints aren't open. Okay. Angle, now they're open. Ta-da. So that angle is according to the position of the toes. Right? Okay, now, just remember when we did the, we talked about doing the scaphoid, and we could angle the tube,
Okay.
right?
Yeah.
Or we could put them on a 15-degree wedge sponge and not angle.
Mhm.
Same thing with the toes, same concept. Joints aren't quite open, but these guys here, you'd have to kind of pull them open. Patient might not like it though. Okay, so when we do oblique toes, if we were doing all of them, okay, we're going to position it in the same way as we would a foot. All right, so it's going to probably be about 45 degrees. If we're doing individual toes, then we have to separate them. Okay, so here, we're doing the 4th toe. And here, we're doing the great toe. And the obliques are just dependent upon which oblique's going to put the part closest to the image receptor. Remember our rule? Part closest to the image receptor. Both joints, part closest to the image receptor. Lateral toes are the most funnest of them all. It's like going on a roller coaster. Okay, so this is just using some cotton. That is not cotton, it's a gauze sponge back there. We're usually collimating just to the toe, but we know they're going to be open a little bit for 2 reasons. One, to include the marker, and the other because we know the collimators are off a little bit. The Friday lab group, of course, they're not real happy with me about it, but I had them do some experiments showing how much the collimator is off. Okay, Monday group, I'll try and show those to you. I won't have you do them though, do the experiment. We'll do something else. Okay, so there's your toe. What's that?
That's my.
It's a sesamoid. Okay, so here we're using a tongue depressor to get number 2 out. Okay, there it is. How many of you have seen toes in the hospital? Not, you don't do them very often.
No, no.
Yeah. Okay, there's number 3. There's a little piece of tape up there. If you're using tape, I suggest you take it all the way over to the edge of the table. Okay, and for those of you that are doing these on the mats, you can't tape to a sheet because it moves. That is taped to the table. Okay, there's 4. You can actually see the tape, so you don't want it over the area of interest. There's a pinky toe. Now, if you have a fractured pinky toe, you're not going to be able to do it that way. You'd have to use tape. Okay, any of you ever stubbed your toe? And you tried touching your toe? Even though it wasn't broken, it was extremely excruciating. I'm going to say, if that toe is always going to get in the way, why do we have it? You know? I mean, can you think of how it must have been before people had shoes?
Well, then it would just get the next one up would be one that was.
Oh, that's true. That's probably, yeah, probably just.
It's gonna happen.
Yeah. Okay. And of course, these are gorgeous pictures because they're in a textbook. Yours will never look like that. Okay, so for the feet, the angling. Okay, angle 10 degrees. Okay, that's because of the arch, right? And if you have flat feet, if your patient has flat feet where the entire foot, surface of the plantar surface of the foot is touching the table, you probably only need an angle 5 degrees. And I'm not going over anatomy, I'm just doing positioning. Oblique. 30 degrees. Toes are 45. There we go. Okay, approximately 30 degrees, 35, sometimes referred to as a shallow oblique. That, we have the soft tissue just posterior to the oscalcis is cut off. We would need to have our cones open more than that. Now, back in the olden days, we would do 2 images on one film. So that's why you see that lead shield there. And I know Raphael talked about that, didn't you?
Yeah.
No?
Yeah.
You were absent that day.
No, I wasn't.
Okay. Lateral. Hang in there. I see why Raphael gives you a break. Well, too much information to give you a break. All right, so lateral, we see we have the plantar surface perpendicular. And the foot is dorsiflexed. Looks pretty, doesn't it? Okay, laterals, standing, weight bearing. Okay, APs, angle 15 degrees towards the heel. We're doing these on the floor. If this is, the tables, most of you know your tables have footboards, if they're floral tables, and they tilt. So you could use this device as a way of doing standing feet if your tube doesn't go low enough to the floor. All of your facilities now have some kind of device to make it easy for us to do standing feet. Thank goodness. Okay, so on the lateral, and notice that on the lateral here, we have equal distribution of weight. Now, some places, the doctors may want you to do a weight bearing with all the weight on the injured side. I think that's probably because when we walk, we always have one foot off the ground. So it would be in our natural position. Okay. What it doesn't have up here is the oblique lateral, the standing oblique. And the standing oblique, we angle the tube 30 degrees. Okay, 30 degrees, just like we obliked at 30 degrees. So angle the tube 30 degrees and it enters in the lateral border just like it's a lot more lateral on this. Okay, are you all gonna make it for a couple more images?
Uh-huh.
Okay. I want to do the earlier ones on the knee. I think that will be more helpful to you. What do you think? You should remember tib fib and all those guys. Where is my cursor? Crap. So this doesn't stay. Okay, hit slivers. Here's the. Yeah, and I'm gonna show you, show you why I have that. Okay, so, John is up here mumbling at this, why do you have planes in the body? Okay, I put this on here so I can remember to remind you all that the planes run through the entire portion of the body. It's just that if we say mid-sagittal plane, it runs through the middle. But otherwise, there's the sagittal planes, sagittal planes are parallel to the mid-sagittal plane. Same thing with the coronal plane. So even though we're positioning down here, remember the entire body because it's attached to the patient, just like the upper extremity is attached to the patient. That's why it's there. Okay, knee. These are Raphael's. I don't think we have one. Okay, so we have oodles, an AP, medial oblique, lateral oblique, and it helps you think medial internal, lateral external. Lateral, then we have PA axial tunnel. Okay, and the tunnel is what? The intercondylar fossa. That's what they should put there. But this is a way they write it up. Okay. Then we have the tangential, so this is the setagast or sunrise. And then we have the tangential merchant method. IR will be an 8 by 10 or 10 by 12. If I'm doing Annie or Nguyen or Colleen or Natalie, I'm going to use an 8 by 10. Okay? And probably half of the rest of you. Always use the smallest image receptor possible. If you're centered correctly, it's not a problem. 40 inches on these. Central ray is a ½ inch still to the apex of the patella. We're centering over the joint, so we don't have to worry about divergent ray. Collimation, and it's easy peasy to shield. The gonads. Poor little gonads, they take such a beating. Trying to get to the picture. Okay. For here, if the hip joint and the knee joint are in the same plane, you'll angle caudate slightly. And we know now because of the angle of the patella, the femoral, the tibial plateau is at a 5-degree angle, right? I don't know why, because we want to get that open. Okay, so if they have a little more adipose down here, because our bones are all pretty much the same size. They have a little more adipose down here. Now, remember, if it's solid, then yeah, that's why your hip joint is going to be elevated. But if it's all flappy back there, it just kind of smooshes out. So you may have some people that even though you look at them and they have a lot of adipose, when they lie down, it just smooshes. So they end up being more like this one. But at any rate, if they don't,
It could be a lot of muscle too.
if it was muscle, then definitely, yeah, you could have some really tight glutes. That's right. So, then the beam is going to be perpendicular. And if we have lots of this is gonna be atavis, that's not glutes. Okay. Then we're gonna angle cephalad. Most of your texts angle cephalad, notice that?
Mhm.
Okay, it's because they can't remember all this. And this has only been since 1992. So in the scheme of our profession, this is relatively new. Okay, it's relatively new, and you all come in there and you say, where are the calipers? I gotta measure. And they say, calipers? Oh, calipers? Anyway, and they might find them, they might not. Then they say, oh, just take it. If you worked for an orthopedic doctor, that's what you would do. Okay, I'm not interested in all that. Okay, here we go. Nice note. This one's angled cephalad. She sure doesn't look, what was it, 28? She doesn't look 28, but as I said, if I look at the joint space here in the tibia, then I'm angled. Okay? Yes?
You also make sure that the beam is exiting out through the popliteal crease?
Yeah.
Okay.
Yeah. Okay, so if we're centered correctly, there's the apex of the patella. There's where our central ray is. That's where it should, about where it should exit, yes. Okay, standing knees. The biggest mistake we make with standing knees is we do not have them true AP. People do all these weird things with their feet. Okay, so I have my patient bend their knees slightly. If I bend my knees, look where they go.
Yep.
Okay, so if you have me bend my knees and you say, oh my goodness, those guys are angled in. So you're gonna say, oh, well, you bring your feet out just a little bit so that my patellas, so I'm true AP here. Okay, that's what I want. So,
So you could do that by just doing a visual of the patellas rather than feeling the front.
I do both.
Uh-huh.
Yeah, I do both. Look at me having all sorts of visitors. Okay. Physics doesn't start until 11, right? No, okay. But your centering is gonna be the same here. No, we do not angle because it's weight bearing and we wanna see that natural joint space. Now, notice we're not quite open there and we're not going to be, especially, now this picture here is of a patient that has lost a lot of their joint space. Should be open more than that, that's pathology. But if you're positioned correctly, that's not an issue. Okay, Rosenberg. Okay, there's that 10 degrees caudad to make it parallel to the tibia, tibial plateau. There are two ways of doing this. Okay, if you're going to have them with the feet away, you don't want the feet underneath the knees, they should be more posterior. If you're going to have them do that, yeah, you can flex and hold. It's when I've seen some of the texts, they put the feet right underneath the image receptor, and then they're having the patient do this, like they're skiing. Okay, that's really not terribly safe, okay? But this one, the most correct way to do it is going to be the feet are not underneath the knees. So we're doing this. Even I can do this. And I have the worst knees in this classroom. Okay, I'm skiing. I'm simulating skiing here. Okay. Okay, so here's the one with leaning. She's on her toes. Okay, this is the one I'm not too thrilled about. Well, no, this is actually the one I would prefer than to have them doing this one. Tech wanted me to do that. I said, you want me to what? Okay, so the obliques, easy peasy. 45 degrees. Medial and lateral. Okay, medial rotation. We see the lateral plateau. That's what's best demonstrated. We should be able to see completely open tibiofibular articulation. Okay, for the lateral rotation, we're going to see the lateral plateau. This one actually should be open more than that. You know you're properly positioned because the fibula is superimposed over the tibia. And on both of them, we just have maybe, I'd call that what, maybe less than a quarter, a fifth. A fifth the patella peeks out at us on the obliques. Have one more minute. Okay, for the lateral, don't forget to flex the knee. Ankle, 5 to 7 degrees caudad, depending on the relationship of the ankle, knee, and hip. Okay, this is actually flexed too much and too tight of collimation, but we shows you 5 degrees cephalad angle. Pretty open here, and again, this person has degenerative changes. There should really be more space here, patellofemoral joint space, but we can see the condyles are nicely superimposed, and the eminences are right in the middle there. This is about a little less than a third superimposition of the fibula and the tibia. Okay, Humblot. That was the one. We're right back at where we started. So you've now had everything. Okay? Is it Humblot you had on Wednesday, right? Okay. If I could turn this upside down, you would see it is the same as the, what was it? The one we started with. I never could remember the name. It's not Humblot. I'm gonna go forward with here. Setagas.
Oh.
Is it Setagas? No, Setagas is neat. Camp Coventry. Okay, the Camp Coventry, you know, it's just one's prone and the other, this one here is, got one with it, where's the kneeling one?
Both from.
Okay.
Aren't they both from?
That one actually has a name, but I have no idea what it is. These two names I know you have to know. Okay? This is really fun to do on a person that has a fractured patella. That's why we know multiple ways of doing things. Okay, that's it. You've had from femur, knee, tib, fib, ankle, foot, and toes. You're ready to go on Wednesday. Make us proud. Don't have Raphael come in and tell me, what did you teach those guys on Monday? No. He would never say that to me. Actually,
Oh, sure. It's just angled.